It is my pleasure to welcome Dr. Jiang Ye, Professor of Medicine and Interventional Cardiologist at Zhejiang University in China. Today, we'll be discussing his JACC Interventions manuscript, assessing angiographically derived index of microcirculatory resistance, or IMR, in patients with NSTEMI. Dr. Jiang, thank you so much for taking the time to join us and share your expertise.
Thank you for your invitation. It's my pleasure.
First, can you give us a brief background about the topic, the questions that you and the team aim to answer, and the population that you studied?
Okay, so actually, our team always focus on, the coronary physiology. So
Hmm.
maybe about 6 or 5 years ago, I found, at that time, the computational physiology such as QFR becomes quite popular. So I discussed with our engineer, can we use angiogram to calculate IMR? Because, IMR is quite useful. Maybe we know in 2004, William Fearon, they published paper, regarding the invasive IMR, the value in predicting, the MACE event in patients at STEMI. But, practically invasive IMR, it's a little challenging, it's a time and cost. It's not widely used in clinical practice. So actually, we really need an easy way, to assess the actual microcirculation of the resistance and how to identify patient with high MR, and we can further treat them. So after we discussed with our engineer, we finally developed this software and validated in 3 cohorts, to show its diagnosed performance. But the team from Samsung in Korea, they go fast. They use their own, one single center study the value of angio-IMR in patients with STEMI show, it's really as good as invasive IMR. So then, at that time we say, what about the non-STEMI? They are not be reported yet. So that's all the beginning of this study. So to increase, the value, actually we cooperate with 2 other big centers in China, Renji Hospital and Shenzhen Hospital in North. So totally we had more than 2,000 cases. So
Wow.
that's the
And
beginning
then,
story.
yeah, nice. And then I think that's a very nice introduction to it. And we briefly mentioned the population, but what did you guys find? And I think one specific thing that would be interested for the listeners is how did you come up with the IMR cutoff? Was it, a previously defined cutoff, or did you come up with your own cutoff?
Actually, our initial manuscript, we set a cut point to 20 because according to our statistics, we found that in patients with angio-IMR greater than 20, the event rate will be significantly increased. But
Mhm.
however, as we carefully discussed with the editors and also, with the previous studies, we finally extended the cut point to 25 to inconsistent with the previous studies and easier for people to use or remember.
Okay.
But well, we should keep in mind in this population, once angioedema is greater than 20, the risk will be significantly increased.
Hmm. And what were the results, especially with the cutoffs of 25 that you guys published?
Okay, we found that in patients with angioedema greater than 25, their risk MACE rate, the risk will be increased. HI is greater than 4, so significantly increase the risk, both for death, myocardial infarction, hospitalization due to heart failure, and TLR. So it's a strong predictor for the MACE events. And also we combine it with our traditional risk factors such as risk factors and also the grade scores.
Hmm.
It can increase in this model combined with that angio-MI, we can get greater AUC area and it's better prediction ability.
Amazing, and truly impressive results. And how do you think we should incorporate these results in clinical practice, and how do we move forward with these results?
Yes, I think this is quite easy. You just input the image into the workstation. Maybe in 1 minute we can get the result, both FFI and
Hmm.
MR. If the patient high MR, so maybe we should use further interventions. For example, before we finish the procedure, maybe we can give in some intracoronary
Hmm.
vasodilators, such as a calcium channel blocker or anticoagulant or nitroprusside, to see if it can reduce the angio-IMR. But of course, it's retrospective studies. It just still has its limitations. So I think in the future we need to confirm its value in prospective studies, and maybe you can even do some random trials. For this IMA high patients, can we give some oral medications to improve its long-term prognosis? It's our future plans.
Amazing. And yes, absolutely. I think we now we can categorize the high risk patients. The question is how we can figure out how to decrease that risk moving forward. Thank you so much, Dr. Jiang, for joining us today. And we invite everyone to go over the full manuscript published in this issue of JAK Interventions. Thank
Mhm.
you again.
Thank you. Thank you for your invitation. It's my honor.